Hello, friends. Today we are going to discuss the International Society for Heart and Lung Transplantation guidelines for the care of heart transplant recipients. So, last week we have this patient who was 46-year-old male patient was a known case of non-ischemic cardiomyopathy. He was admitted in our hospital in 7th of December 2022. So at that time, he came in our hospital following cardiac arrest. Then he landed up into this cardiac arrest lasted for approximately 30 minutes. He revived that, and then he landed up into the cardiogenic shock with multi-organ failure. He was on VA ECMO for several days, and then he came out successfully from that. After that, in view of reduced ejection fraction, he was on the AICD, and then he was listed for the heart transplant. And finally, on 31st of August 2024, he underwent heart transplant. So from the day of operation till today, he has faced many complications, which included right ventricular dysfunction, reduced cardiac output, vasoplegia, coagulopathy, arrhythmias, and because of these all these complications, we were suspecting rejection. So we will see how to deal with this all complication and how to take care of early how to take care of this heart transplant recipient in the early post-operative day. So it is advised that perioperative monitoring of the heart transplant recipient include continuous ECG monitoring, post-operative 12-lead ECG, then invasive arterial pressure monitoring should be there, direct measurement of right atrial pressure or central venous pressure, measurement of left atrial and pulmonary artery wedge pressure, intermittent measurement of cardiac output, intermittent measurement of systemic vascular resistance, continuous measurement of arterial oxygen saturation, intermittent measurement of mixed venous oxygen saturation, intraoperative transesophageal echocardiogram, con- continuous assessment of urine output. Then this tricuspid valve regurgitation, identified intraoperatively and estimated to be moderate or severe, should be reevaluated by transthoracic echocardiogram or TEE within 24 hours of heart transplant and closely monitored for first few post-operative days. The frequency of subsequent follow-up should be guided by the clinical and hemodynamic variables. This has class 1 recommendation. Then we should look for the pericardial effusion with the help of echocardiogram. This also has a class 1 recommendation, level of evidence C. Then the next on the when patient came in our ICU, he was having right ventricular dysfunction because the TAPSE that we measured was on first day it was 12, next day it came out to be 10. And the patient was hypotensive on multiple inotropic support. The hemodynamic monitoring that we have attached was showing the continuous low cardiac output. So we will first see how to deal with this vasoplegia. So refractory vasoplegic syndrome, that is persistent low vascular resistance, is observed in 11 to 60% of heart transplant patients, and hypotension occurring within 24 hours of the heart transplantation. Cardiac index is greater than 2.2 and systemic vascular resistance is less than 800. So what is the pathophysiology behind it? So this vasoplegia is associated with cytokine release, adrenergic receptor desensitization, increased nitric oxide synthesis, relative deficiency of vasopressin, then activation of ATP channels, vascular smooth muscle cell membrane hyperpolarization, dysfunction of renin-angiotensin system, and endothelial glycocalyx alteration. Now, how to manage it? So norepinephrine is considered the first line agent for treatment of vasoplegia followed by vasopressin. And other routine vasoactive medications include epinephrine, norepinephrine, dopamine, angiotensin 2. The additional use of single dose of methylene blue may also be considered. We haven't used this in practice anytime, but it is given in the guideline, and all this treatment has a class 1 recommendation on level of evidence C. So next problem that the patient has faced was the right heart failure. The TAPSE was persistently low. So this right heart, now we will see how to deal with this. Now the right heart failure is a severe complication after heart transplantation and contributes significantly to the morbidity and mortality. So right heart failure is related to the secondary graft dysfunction, and the other etiologies are hyperacute rejection, non-surgical complication, and pulmonary hypertension. So as a presence of the P-transplant pulmonary hypertension in heart recipient, it increases the risk of post-transplant right heart failure. So it is saying that this heart failure with reduced ejection fraction already they are pulmonary already they are having high pulmonary artery hypertension, and that is the reason for this post transplant right heart failure. So the we should be very vigilant for while selecting transplant recipient, and their pre-treatment optimization of hemodynamics should be done properly. So how to deal with this? So vasodilator challenge with the inhaled and the intravenous vasoactive agent should be administered. So when we should administer it when systolic pulmonary artery pressure is 50 mmHg or greater, and when transpulmonary gradient is 50 mmHg or greater, pulmonary vascular resistance is greater than 3 volts, and systolic arterial blood pressure should be maintained greater than 85 mmHg. The management of right heart failure also relies on preservation of coronary perfusion through maintenance of adequate mean arterial pressure using norepinephrine infusion. And optimization of right ventricular preload is needed with the careful monitoring to avoid congestion. Then we have to reduce the right ventricular afterload by decreasing pulmonary vascular resistance. Now, the limitation of pulmonary vasoconstriction through appropriate ventilatory setting should be done. That is to avoid hypoxia and hypercapnia. Inotropic agent that can be used to augment the right ventricular function include isoprotenolol, milrinone, enoximone, dobutamine, and epinephrine. This has class 1 recommendation level of evidence C. Systemic vasodilator with pulmonary vasodilating properties include nitroglycerin and sodium nitroprusside in the absence of systemic hypotension. This statement has class of recommendation 2 level of evidence C. The selective pulmonary vasodilator can be used in the management of perioperative RV dysfunction. That is, so we can use in this case like prostaglandin, inhaled nitric oxide, and sildenafil. So this statement has a class of recommendation 2A level of evidence C. So as we have seen in the guideline, the class of recommendation 1 and level of evidence C has been given to isoproterenol, milrinone, enoximone, and dobutamine and epinephrine. So if the heart failure is not settling with that, then then uh, so the relative efficacy of inhaled ipoprostenol appear to be similar to the inhaled nitric oxide, and its use may be associated with the significant cost saving. And if the heart failure is not settling with all these measures, then the next step is the use of mechanical circulatory devices like VA ECMO. Uh, then other forms also we can use like left ventricular assist device, right ventricular assist device, and biventricular assist device. So the use of a mechanical circulatory device has a class of recommendation 1 and level of evidence B. And this mechanical circulatory device should be initiated early if there is a failure to wean from cardiopulmonary bypass and other evidence of heart allograft failure, such as requirement of multiple high-dose inotropic agent to permit separation from the CBP is required. This statement has class of recommendation 1, level of evidence C. MCA should be considered when there is continued or worsening hemodynamic instability, like decreasing cardiac index and falling MBO. So on same day, when we have observed this patient throughout the day, his cardiac output was persistently low, and that's why we have initiated ECMO. Now we will see the what are the recommendation of ECMO. In between, the patient's urine output was low, so we have started him on also on the CRT. Now, according to the guidelines, the recommendation for the ECMO is the use of ECMO should be considered when there is a failure to separate from the cardiopulmonary bypass. After all correctable causes of such a failure have been excluded, ECMO should be promptly instituted when progressive heart allograft dysfunction occurs post-operatively, and the amount of circulatory support provided by ECMO should be sufficient to achieve adequate systemic perfusion and oxygen delivery while waiting for myocardium to recover. So, left heart distension during ECMO support should be aggressively treated because it compromises pulmonary function. Clinical and echocardiographic variables should be serially assessed to determine if myocardial recovery is occurring or not. Objective signs of recovery should lead to weaning and discontinuation of ECMO support. Lack of objective evidence of myocardial recovery within 3 to 5 days should prompt consideration of either institution of long-term MCS or as a bridge to recovery or heart transplant or withdrawal of life-sustaining therapy. Then next day, this patient had decrease after installing ECMO. The next day, this patient has the decreased perfusion of the left leg, and then the site of that ECMO cannula was changed. Initially, it was on the left side, and it was put on the right side. Then after that, from that ECMO side, there was a continuous bleeding. So we thought this patient is dealing with some bleeding. Now we will see how to deal with the coagulopathies in the heart transplant patient. Now the first is risk assessment. An assessment of the perioperative bleeding risk include the history of post-traumatic and post-surgical bleeding, family history of the bleeding, the use of medication that alter coagulation, liver disease with elevated MELD score should be carefully evaluated. Then screening coagulation tests such as prothrombin time, activated partial thromboplastin time, platelet count should be measured immediately before heart transplant surgery. Adequate anticoagulation is assessed by activated clotting time should be obtained before initiation of cardiopulmonary bypass, and it should be assessed at regular interval during heart transplant to judge the activity of the heparin. This has class of recommendation 1 and level of evidence C. The perioperative viscoelastic test, like take and rotate, may be useful in evaluating anticoagulation status. Now, the post-operative measurement of fibrinogen and D-dimer are essential when we are suspecting the increased risk of bleeding after heart transplant. Uh, and it is measured in the identified as having specific increased risk for vascular thrombosis. Now, the platelet function can be measured either by platelet aggregometry or by the point of care assay, such as platelet function assay during heart transplant surgery. Now, thromboelastography may be repeated after heart transplant surgery to monitor patient's hemostasis. Then anemia screening and management for patient listed for heart transplant is recommended. Preoperatively, INR should be reduced to less than 1.5. Four-factor prothrombin complex concentrate and vitamin K should be considered for INR reversal as they have been shown to be safe, effective, and reduced intraoperative blood product utilization. A protocolized approach to warfarin reversal should be utilized for left ventricular assist device patient admitted for heart transplant. Then warfarin should be given in preference to direct oral anticoagulant in patient actively listed for transplant who require systemic anticoagulation. Given the need for rapid normalization of INR, chronically anticoagulated patients who are about to go for heart transplant should receive vitamin in conjugation with FFP, prothrombin plasma concentrate, recombinant factor 7, depending on their availability and patient's renal and hepatic function. This statement has a class of recommendation 1 and level of evidence C. The absence of platelet factor 4 and heparin antibodies should be confirmed. The use of unfractionated heparin should be restricted to operative procedures itself. The low molecular weight heparin is not recommended due to their longer half-life than unfractionated weight heparin and inability to reverse its effect with protamine. This statement has class of recommendation 1 and level of evidence C. Heparin use for CPP at the time of transplantation is reasonable in also in patient with heparin-induced thrombocytopenia, but provided that patient should be negative for IgG antibodies against platelet factor 4 and heparin complex before heart transplant, and then we need to monitor platelet aggressively for next 5 days with the use of non-heparin anticoagulant if systemic anticoagulation is required. So, HIT antibody testing before transplant listing is reasonable in patient with history of heparin-induced thrombocytopenia, ideally at the time of admission for heart transplant. Now, the low dose aspirin that is less than 100 mg daily are reasonable for recipient listed for heart transplant with indication for this therapy is feasible. This statement has class of recommendation 1, level of evidence C. Alternative anticoagulation can be used preoperatively and postoperatively in patient with history of heparin-induced thrombocytopenia in whom platelet count has recovered, but IgG antibodies to platelet factor 4 and heparin complex are still present. This statement also has class of recommendation 1, level of evidence C. Patient with abnormal hepatic and normal renal function can be treated with lepirodine, danaparanoid, fondaparinux, whereas those with abnormal renal and normal hepatic function can receive argatroban as a standard dose or lepuride at a reduced dose. This statement has class of recommendation 1, level of evidence. Patient with both renal and hepatic dysfunction can be treated with argatroban and bevalirudin at reduced doses. Then transfusion of coagulation factor is necessary for adequate hemostasis. Thus, fresh frozen plasma and platelet should be transfused based on major flow. Fibrinogen infusion for massive bleeding and inadequate fibrinogen level is needed. Then point of care coagulation test should be utilized to inform perioperative blood product administration. This statement has class of recommendation 1, level of evidence B. Then tranexamic acid and epsilon aminocaprinic acid both have antifibrinolytic activity, can be used before CPB to reduce the risk of bleeding in selected patients. Recombinant factor 7A may be utilized as last line therapy for refractory hemorrhage. 4-factor PCC up to 50 units per kg and 5,000 unit total should be utilized ahead of recombinant factor 7 in case of persistent bleeding. 4-factor PCC up to 50 units per kg or 5,000 unit total should be utilized in ahead of recombinant factor 7 in case of persistent bleeding. The routine use of aprotinin and desmopressin is not recommended because its modest reduction in bleeding has been associated with adverse clinical events. Now, regarding the management of arrhythmia, next day this patient has one episode of supraventricular tachycardia and persistent arrhythmias, atrial fibrillation. So, for that supraventricular tachycardia, we have given Cordron, and then because of the multiple episode of atrial fibrillation, he have received one shock and continuous infusion of Cordron. Now, we will see how to deal with this arrhythmias. Atrial and ventricular temporary epicardial pacing wire should be placed at the time of heart transplant, even if initial rhythm is silence. This statement has class of recommendation 1, level of evidence B. After heart transplant, temporary pacing should be initiated in setting of relative bradycardia. This statement has class of recommendation 1, level of evidence B. Recommendation for permanent pacing exists for inappropriate chronotropic response 3 weeks after heart transplant. Then treatment of tachyarrhythmia should be aimed at rate control. Persistent tachyarrhythmia, whether atrial or ventricular, should prompt investigation for possible rejection and electrophysiological evaluation if rejection is absent. Then sustained ventricular SVT should be evaluated with both angiogram and endomyocardial biopsies. All this statement has class of recommendation 1 and level of evidence B. That means if the patient, if our heart transplant recipient has a persistent tachycardia, tachyarrhythmias, then the possibility of the rejection should be high. So how now next is how to treat with this all arrhythmias. So class 2 antiarrhythmic like sotalol and amiodarone can be safely used in heart transplant recipient and have minimal interaction with the immunosuppressive agent. So this non-hydropyridine calcium channel blocker and beta blocker may be used in heart transplant recipient for rate control. Adenosine may be considered in heart transplant recipient with supraventricular tachyarrhythmias if they are closely monitored and low doses administered. Now, the next we were thinking about rejection. So we will see how to evaluate for allo sensitization, how to deal with hyperacute and late rejection, and what is antibody mediated rejection. So first is allosensitization. So transplant candidate might manifest circulating antibodies against the human leukocyte antigen and non-human leukocyte antigen. Where this condition is termed as allosensitization. So the presence of these antibodies decreases the given candidate possible donor pool, thereby prolonging time to transplantation. Now the evaluation for allosensitization and approaches to sensitized heart transplant recipient. So screening panel reactive antibodies should be performed in all heart transplant candidates. When PRA is elevated, that is more than 10%, then further evaluation is recommended. The specificity of circulating antibodies should be determined with the solid phase assay, such as flow cytometry, if possible, in regional certified human leukocyte lab. Anti-HLA class 1 and class 2 specificities, that is, in any HLA antibody directed against HLA, HLA-B, HLA-C, HLA-D, and HLA-DQ antigen should be defined. In the absence of international standard, each transplant center must define antibody threshold for unacceptable rejection risk. A mean fluorescence intensity less than 5,000 is generally considered to be an acceptable threshold. It is recommended that circulating panel reactive antibody based on recipient antibody specificity and population antigenic prevalence be determined. The complement fixation capability of detected antibody may be beneficial as it may identify more clinically relevant antibodies. If known, presence of non-HLA antibodies like MHC class 1 polypeptide related sequence or angiotensin 2 type 1 receptor activating antibodies or antibodies to self-antigen are reasonable to report and consider when assessing antibody-mediated risk. The prospective and virtual cross-match should be performed in recipient with the panel reactive antibody of more than 10%. Complete patient sensitization history, including previous panel reactive antibody determination, blood transfusion, pregnancy, implant of homograph material, previous transplantation, and the use of ventricular assist device is required to assess the risk of heart allograft antibody mediated rejection. If PRA more than 10% indicates allosensitization, however, many centers use PRA more than 50% as a threshold for desensitization. The result of retrospective donor-recipient cross-match may be considered to make decision regarding immunosuppressive therapy. Desensitization therapy should considered when calculated PRA is considered for individual transplant center to be high. Now, the choices to consider as a desensitization therapy include IV immunoglobulin infusion, plasmapheresis, either alone or combined, rituximab, and in very selected cases, splenectomy. A patient awaiting transplant, the presence of anti-HLA antibodies can be reassessed 1 to 2 weeks following sensitizing event to reduce the possibility of positive crossmatch. In allosensitized individual, including those undergoing desensitizing therapy, it is reasonable to monitor anti-HLA antibodies at regular interval according to their urgency status until the compatible heart allograft become available to reduce the possibility of positive cross-match to facilitate match. In ambulatory non-sensitized heart transplant candidate, it may be reasonable to measure anti-HLA antibodies every 6 months. In heart transplant candidate requiring blood transfusion, anti-HLA antibody determination should be repeated 1 to 2 weeks later, and prospective donor and receptive cross-match is required in inter-period if suitable donor organ become available. Measuring circulating immunoglobulin before and after plasmapheresis and immunoabsorption may be useful to monitor response to therapy. Measuring lymphocyte subpopulation before and after the use of rituximab may be useful in guiding therapy. Biopsy samples obtained for surveillance of rejection should be assessed for both cellular and antibody-mediated rejection. Now, if we are dealing with hyperacute rejection, then how to deal? So the treatment options are high-dose IV corticosteroid, plasmapheresis, then IVIG, rituximab, eculizumab, IV calcineurin inhibitor, heparin, inotropes, and vasopressors. Placement of the mechanical circulatory support system should be considered as a bridge to retransplantation. Urgent retransplantation may be considered and is associated with increased mortality. Now, the next is antibody-mediated rejection. When antibody-mediated rejection is suspected, then endomyocardial biopsy examination should include AMR pathology assessment and classification according to ISHLT grading. When AMR is suspected, recipient serum should be evaluated for presence, quantity, and specificity for anti-donor antibodies. Serum sample should be drawn before initiation of therapy to avoid assay interference from therapeutic agent. Now, these are the categories for reporting AMR. So, if grade 0 means it is negative for pathologic evidence is negative, then negative for that is histopathologic and immunological studies both are negative. Then grade 1 means only histopathological evidence is there but no immunological evidence. Grade 1 means grade 1 okay. Grade 1 I plus means only immunological evidence is there, no histopathological evidence. Then AMR grade 2 means pathological antibody mediated reaction, that is histopathological and immunopathological finding both are present. And grade 3 means severe pathological AMR, that is interstitial hemorrhage, capillary fragmentation, mixed inflammatory infiltrate, endothelial cell pycnosis, caryxis, marked edema will be there. Now, the recommended therapies are high-dose intravascular corticosteroid, cytolytic immunosuppressive therapy, rituximab, bortezomib, cartilozomib, eculizumab. And maintenance therapies include conversion from uh, cyclosporin to TAC or from azathioprine to MMF, replacement of azathioprine and MMF with TOR inhibitor, increasing target trough level and addition of low dose corticosteroid and additional immunological monitoring is recommended. The following treatment may be used to remove circulating anti-HLA antibodies like plasmapheresis, immunoabsorption, and IVIG. The following treatment may be used to maintain adequate cardiac output and systemic blood pressures like IV inotrope, vasopressor, and MCs. Systemic anticoagulation may decrease intravascular thrombosis in heart allograft, and emergent MCS may be considered as a bridge to retransplantation if above measures do not restore the acceptable heart allograft function. Emergent retransplantation following acute rejection is associated with unfavorable outcome. So these are the examples of therapies for antibody-mediated rejection. Plasmapheresis, then the dose is 1 to 2 plasma exchange daily or every other day. We have to give this for 3 to 5 days. Then IV immunoglobulin 100 to 2000 mg per kg. Low dose 1 to 3 times per week, often given after each plasmapheresis. Then rituximab we can give, that is 375 once in a for 1 to 4 weeks. Then follow-up endomyocardial biopsy should be performed every 1 to 4 weeks after initiation of therapy and include immunohistochemistry examination also. Then according to that, we have to adjust the maintenance immunosuppressive therapy. Then how to deal with late acute rejection. So maintenance of immunosuppression and intensity of clinical follow-up should be re-evaluated after symptomatic and asymptomatic late acute heart allograft rejection. So after the first year, continued rejection surveillance is reasonable in patients who are at high risk of late acute rejection. So risk factor for this rejection is younger recipient age, prior history of acute rejection episode, presence of donor-specific antibodies, female recipient, female gender, rejection event occurring more than 6 months after transplantation, calcineurin inhibitor reduced or free immunosuppression, and history of medication of non-compliance. Then repeated education on critical importance of adherence to treatment and early reporting of symptoms contribute to prevention and early recognition of late acute rejection. Patients at risk of late rejection do not appear to significantly benefit from endomyocardial biopsy surveillance. So usefulness of long-term routine EMB should be evaluated against the risk and cost of procedure. And repeated biopsy increases the probability of damage to tricuspid valve apparatus and collection of non-diagnostic material. So in pediatric and adult heart recipient, this coronary allograft vasculopathy should be considered if differential diagnosis of late symptomatic and asymptomatic rejection when heart allograft dysfunction is present. So coronary angiography and intravascular ultrasound and optic coherence tomography should be considered in this patient during long-term follow-up. So these are the grades for cardiac allograft vasculopathy. So grade 1 means not significant, no detectable angiographic region. Mild means angiographic left main is less than 50%. Grade 2 means angiographic left main less than 50% and single primary vessel is more than 70% involved. Isolated branch stenosis more than 70% in branches of 2 in the system without allograft dysfunction. Grade 3, that means severe, is allographic left main graft more than 50% involved, 2 or more primary vessel more than 70% stenosis, and isolated branch stenosis more than 70%. So antibody-mediated rejection is more commonly identified in late acute rejection compared to acute cellular rejection and should be considered in differential diagnosis of heart transplant recipient presenting with signs and symptoms of heart allograft dysfunction. So EMB with immunopathological evaluation as well as measurement of circulating HLA donor specific antibodies should be obtained before initiating treatment. In the absence of disseminated infection. Now regarding infection part, so if disseminated infection is absent, then bacterial donor should receive antibody targeted to specific antigen. So long course of therapy is recommended in setting of disseminated infection. Initiation of intravenous ganciclovir or vanganciclovir should be initiated within 10 days of heart transplant. Preferred agent for prophylaxis against pneumocystis jirovecii is trimethoprim, and alternative agents are dapsone, atavaquone, clindamycin, pyrimethamine, and inhaled pentamide. Thank you.